So assessing the child who's having breathing difficulties, it is important to expose them all the way to the waist, particularly during the history, so that by the time you get to more formally assess them, they're comfortable and happy. Observing the breathing gives you most of the information. You can look for the increased work of breathing and also looking at the respiratory rate. Also get a general appearance of the child. One of the most common reasons for breathing difficulties is wheezy respiratory illnesses. Is the child atopic? Does he have allergic shyness, which is where the child's been doing this all the time? Or does he have a crease across his nose from the allergic salute? These will all give you clues as to whether the child has wheeziness or asthma. The first thing we'd look is a general appearance. Is the child unwell, well? Does he have a fever? All the vital signs. And then we start looking at the A, B, C, D, E, N, T aspect of looking at the child who's breathless. There are lots of different upper airways noises you may hear with a child who's coming in with breathing difficulty. The most common is going to be the nasal secretions and the snuffliness that you'll hear. Stertor is another word that indicates large swollen tissue behind the nose and the throat, which is quite common in viral illnesses. The other noise to consider is stridor. Now, stridor indicates an upper airways obstruction, and the most common cause in our environment would be croup. This involves inflammation of the vocal cords around the voice box, and in most cases you get a mild inspiratory stridor. Remember, there are other causes of stridor, and so if the stridor is predominantly inspiratory, think of extrathoracic obstruction. If there is an expiratory stridor, think of intrathoracic obstruction such as a foreign body. If the stridor is both inspiratory and expiratory, this is a biphasic stridor, and that indicates the child is in significant distress. In that instance, though, there would be no further need for any examination. This may upset the child and compromise the airways. In this instance, you'd consider getting an adrenaline nebulizer and organising transfer to a hospital. Another noise that's quite important is grunting. This is particularly common in small infants who have a lower respiratory tract infection. Beware of the grunting infant who doesn't have much of a cough. This could easily indicate a pneumonia. Wheeze is another noise that you'll commonly hear and is quite audible, and I like to describe this as the wet sponge noise that parents will describe, and that may require some bronchodilator treatment. Parents describe coughing as dry, harsh, moist, honking, or croup-like. And croup-like cough is quite common in children with croup, but won't be present in the child with a foreign body or epiglottitis. So after airways, we're now looking at breathing, and we're looking at the respiratory rate and the increased work of breathing. The respiratory rate will give us an idea as to how distressed the child is, and it's very important to examine the child while he's comfortable and relaxed, counting the number of breaths per minute. This will also give us an idea as to whether he has a prolonged expiratory phase, which is seen with asthma and bronchiolitis. The increased work of breathing depends on the age of the child. In the infants, you'll see quite significant retractions of the chest wall, but the infant still will appear comfortable and will be feeding well. Whereas in the older child, it will be more subtle to see the difficulty of breathing. Some of the clues working from top down is looking at the nose, looking for nasal flaring around this area. In the child who's upright, you'll see a tracheal tug, intercostal retractions, subcostal retractions, and also recessions. And in the child who's particularly distressed, you'll see a sternal retraction there. But this will be someone who's really working very hard. So now we're going to get to auscultation, and sometimes it's easier to auscultate the child facing the mother, so you can get more accurate assessment of the respiratory tract. Okay, can you do those big breathings for me, Noah? That's it. Good boy. Drop the hands a bit there, Danielle. Percussion is useful, comparing one side to the other to see if there's a pleural effusion. In most instances, the auscultation will only confirm what you already feel is the diagnosis. When auscultating the chest, the most important thing is getting good air entry. Be careful of the older child who has limited air entry bilaterally. This child may well have quite severe asthma, and they haven't generated enough airflow to generate the wheeze that would traditionally be heard with asthma. Wheeze is very common in children, viral-induced wheeze particularly. Other noises to think of are crepitations, which will occur with bronchiolitis or also with the lower respiratory tract infections. Bronchial breathing and effusions would indicate that there's more likely chance of a bacterial component to a lower respiratory tract infection. Don't forget to check for a pleural effusion. Obviously, auscultating Noah was pretty easy, but can be quite difficult. In the noisy toddler with noisy upper airways, it can be hard to establish what is true lower airways noises and what is transmitted upper airways noises, and this takes time and experience. So C is for circulation, and here we're looking at capillary return, colour and heart rate. Now in the child who's having breathing troubles, tachycardia is a significant sign that there is a major illness going on. The capillary return is best in peripherally, assessed with the fingers, pressing for a few seconds, relaxing and making sure that the capillary return is less than 3 seconds. Although remember, this is an unreliable sign if there's a cool ambient temperature. In central capillary return, we can either press the chest or the forehead, and if there is a delay in the capillary return here, then we're obviously dealing with a child who's particularly unwell. After circulation, now we look at D, which is disability and dehydration. The disability assessment has already been done when the child first came in, looking at their level of consciousness, their alertness, their interaction, and also looking to see if they have a limp or a swelling anywhere in their peripheral assessment. The child who's particularly drowsy with a swollen joint, you can think about a joint infection. Also, don't forget juvenile onset arthritis, Henoch-Schönlein purpura, and the child with a limp, a fever, unwell. There's always in the back of the mind think of leukemia, particularly if you find an enlarged liver and spleen when you come to the abdominal examination. In dehydration, we've already looked at his capillary return. We're also looking at his mucous membranes, and in the infant we're looking at the fontanelle and also the general colour. So now we come to the ENT assessment of the child with breathing problems. The E firstly stands for exposure. So have the child exposed, looking for any rashes, bruising, or even an hemangioma, which may indicate that there will be an associated intrathoracic hemangioma. Also don't forget clubbing, which may indicate bronchiectasis or suppurative lung disease. The ears and throat are best left to the end, and the throat examination should not be done in the child with a stridor in case this make this significantly worse. The T stands for tummy, and so the abdominal examination is an important part of this. Gentle examination will find out if they have an enlarged liver or spleen or they have significant tenderness. The enlarged liver or spleen will be associated with some viral illnesses, particularly Epstein-Barr virus, and also you need to consider the possibility of leukemia in the child with a palpable liver and spleen who's unwell, and in addition the abdominal pain findings would be symptomatic of, say, a child with Henoch-Schönlein purpura. And don't forget tender abdomen and breathing difficulties in the child with diabetic ketoacidosis. The temperature is also taken and this will give you a clue as to whether we're dealing with an infectious illness in the child who's having breathing difficulties.